Welcome back to Periop Talk. I'm Jake Runyon, Senior Manager for the Center for Perioperative Leadership here at AORN. Today's episode, we're going to talk about how we can help cultivate a culture of safety and why nurses make great leaders in the periop setting because of this. Today's guest, Pam Hunt, is perfect for this episode because she has cultivated a culture of safety in her own career from bedside nurse to chief nursing officer. Pam also teaches courses on how to effectively advocate for safety through business acumen. Let's dive in.
Welcome to Periop Talk, making surgery safer one podcast at a time, with brief, practical information for you to take back to the OR.
Pam, so great to have you. What role does a perioperative nurse have in creating and maintaining a culture of safety?
Hi, Jake. It's nice to be here. And, in the perioperative space, I would pause there and say more than any other space in the hospital setting or in the healthcare organization setting, the perioperative nurse, the perioperative leader is the protector of the patient because the patient is oftentimes unable to speak for themselves. So there are so many ways that we as perioperative nurses and leaders protect the patient and protect the patient's safety. And it's not just when we're just with that patient, but it's also everything that we do in the perioperative setting, the safe environment that we provide, the attention to detail, to sterilization, opening up that pack and making sure that we are providing sterile instruments to the field. All of those attention to detail elements are providing a safe environment for our patients.
With that being said, what are some common barriers, Pam, in establishing a culture of safety? So how are nurses positioned to overcome these barriers?
When you say barriers to a culture of safety, I oftentimes think of organizations or departments that don't have a speak up culture. That's the number one barrier to safety is I don't feel safe to speak up. And I've done a lot of research recently on courage. And this statement should frighten most of us. The opposite of courage is not cowardness, but the opposite of courage is conformity. So when we don't have the courage to speak up, when we know that processes are not being followed, that procedures are not being followed, that the patient is in a position of potential harm, when we don't have the courage to speak up, then we conform with the poor practice that's occurring.
So eloquently put, at least in my experience, Pam, you can see even pockets of conformity, right? It might be, again, in my experience, it might be if you are being precepted, right? Your preceptor might be that person that's conforming, or in a little bit larger group, your entire team has just become accustomed to that. And it, especially with considering the fact that we have a lot of newer to profession nurses, I can imagine you're seeing out there in the field that is still a challenge. Is that fair?
Oh, that's really fair, Jake. And it really brings home how important that preceptor is. Teaching and learning properly, the right way out of the gate is so critical because you're right. If we are not taught correctly to begin with, how do we know that that's wrong? And then how far does that go as we teach others the incorrect way? So absolutely, those preceptors, and we've been in a situation, many of us, many leaders have been in a situation over the last few years, most recent years, of our preceptors have very little experience themselves. So the education and the qualifications and the preparation of those preceptors is critical to the long-term care, consistency, and safety in that department.
And also, we know in the perioperative areas, you've got a multidisciplinary team, right? You've got the surgeons, you've got anesthesia. Pam, in the various roles that you've served, what types of initiatives or programs have you seen that have helped strengthen that culture of safety across the spectrum?
Well, first of all, I will tell you, I believe it starts with leadership. Being able to be in an environment that says, if you see something, say something, to be able to be in an environment that any idea is a good idea. And if we try it and we fail, that's okay. So, that whole culture and to look at to do deep dives when we do have instances of failure. We're going to have that. To do deep dives when we have instances of failure, to be inclusive on who's in that deep dive, to be inclusive. You mentioned we do have multiple roles in the OR, more so than maybe other departments in the facility. And so when we have a failure that reaches the patient, or maybe even a failure that doesn't reach a patient, which is better yet, when we have a failure that happens, then are we including everybody in the discussion of what was the cause, what was the problem, how would we redesign the process so that this doesn't happen again? And that may mean that we have a surgeon in the room along with an orderly or a nursing assistant or unlicensed personnel. We have so many different titles for the folks that are caregivers in our OR suite. We have all of those people together along with the nursing professionals in the department to problem solve and to determine what could have been better. Those are practices. And, we have the aspects of a high reliability organization. And one of those is to constantly ask questions. Don't accept, as we talked about earlier, don't accept the status quo. If something looks wrong, let's investigate it.
Yeah, Pam, I've had some recent conversations around how you can bring in new technology to help with safety.
Mm-hmm.
And all the companies that I've talked to are very, very good at talking about how the culture needs to be in the right place for even technology to help support a culture of safety. What have you experienced with that? One that comes to mind are the different black box versions that are out there. But again, those companies talk about if your culture is not in the right place, then the technology is really not going to do much for you. Have you seen any of that out there?
If your culture is not in the right place, oftentimes those aids those aids to safety are looked at as a big brother. They're looked at as watching what we're doing instead of they're there to help protect, and they're there to help us become better. So again, it goes back to we're not doing something wrong, but we're constantly looking at what we can do better. But Jake, you talk about technology, and I don't know if it's appropriate right now in our chat together, but I do a lot of work in the financial acumen space. And a lot of times the technology that's out there that protects patient or workforce safety, I want to include workforce in this as well, or workforce safety is often fairly expensive, and it may be difficult to justify that. So we do a lot of work together, me and AORN, in helping leaders understand how to make that business case for patient and workforce safety.
It absolutely is the right time, Pam. Now that you've taken us there, I'd like to even back up just one step. I like to think that every nurse, and I know you do as well, that every nurse is a leader in his or her own right. How you have built a career up to the point where you are now consulting and teaching on multiple different leadership facets, financial acumen being one of them. I want to know, how did you get into, as a nurse, to become so inclined to want to learn more about the financial health of an organization?
Asking the question why. So I always say, some speakers teach critical thinking, and critical thinking is asking, not knowing how to do something, but knowing why you do it. So let's do the crosswalk here. When I was a clinical bedside nurse, if something was, if a piece of equipment wasn't working, or if a supply, maybe we would get a change in supply and it would seem not the same quality as what we had before, I would ask, why did we change this? Instead of just complaining about it, right? Why was this changed? And help me understand why this was changed. And this is what I'm experiencing as a result of the change. So are we really saving dollars if it was because of a dollar change or a dollar savings that we changed? So in that same crosswalk, a good example was that early on in my leadership career, we had, and everybody knows in the perioperative space, when you change a supply because it might involve surgeon or anesthesia, it is kind of a big deal. So when we would need to change a supply because of our GPO, our group purchasing organization, switched a contract, that was sometimes frustrating. So I went to back in the day, it was called materials management. Now it's called supply chain. I went to our supply chain leader and said, I want to know more about the group purchasing organization. I want to know how these contracts are awarded. I want to know what kind of input we have in it, et cetera. Well, that person, you might be surprised, was very happy that I was asking. They were not offended at all. Sometimes that's the way you ask. So that's a whole nother topic, right? But as a result of that, I was perioperative director at the time. I actually had the privilege of sitting on one of those GPO committees for a 3-year period, where we were the committee that tested the products and that trialed the products, that looked at the proposals, and that actually awarded the contracts. So, that was just from a pure question of, change is hard. And when we have to change products, especially when it involves some medical practitioners, it's even harder. So let me learn more about this. And that question led to voice at really a national table of awarding contracts.
It's an empowering story, Pam, of how any nurse can get that voice. Let's tie that back into a culture of safety. So, starting with kind of the cost, how have you then therefore seen the culture of safety contribute to the financial health of an organization, Pam?
Well, anytime, let's go here first. Anytime we have a safety event, think about the resources that it takes to correct that event with the patient. Maybe that's extended length of stay. Maybe that's additional medication. Maybe that's additional support services such as PT, OT, et cetera. So the cost of that safety error is high, and we can actually quantify that in the finance acumen series that we do. We talk about hard cost and soft cost, and many may say, oh, those are soft costs, but you can actually put hard cost to many of what we used to term soft cost activities or instances, and really say, look, if we continue to have, I'll just take an example. If we continue to have pressure ulcers on this type of surgery because we don't have the correct positioning device, and we have X number of those in the next year, and it takes, a 4-day extended length of stay and medication to treat that, besides the loss of community trust, this is what that event is costing us. And so you can put some cost to it and really make the business case for providing the appropriate positioning devices that you need to avoid that pressure ulcer occurring during a long surgery. So that's just kind of another example. But there are numbers out there, and we use if your organization has those numbers and captures those. Some organizations do. That's great. But if you don't think that that's a barrier, because there are some national organizations on healthcare quality that can give you benchmark numbers on those particular instances.
And what I think I'm hearing you say is that not only when an adverse event happens, but also in the effort to prevent an adverse event from happening, you can quantify those costs, whether that be in supply, equipment, so staffing, as you've alluded to.
Mm-hmm.
Is that right?
Yeah, I love the way you think, Jake, because oftentimes in healthcare, unfortunately, we react when we've had a poor patient outcome, an adverse event, or when regulatory tells us. And wouldn't it be nice to be able to take the appropriate steps when we identify them before any of those things occur? And again, it's hard when you don't have something that, I had a president once say, a hospital president say, crisis creates innovation, crisis. I had a hospital president once say that crisis creates innovation. And I would so like to be innovative before there's a crisis.
Bingo. I've heard that before, and I agree. So if you kind of tie in your journey, Pam, and you were talking to a nurse that is always and has always been focused on a culture of safety, what essential components, or where maybe better put, where would they start if they wanted to get into a formal leadership role and think about their business acumen and how that can kind of tie into the big picture? What advice would you give them, Pam?
Well, I would give them advice of continue to, because if the individual that you just described, they're probably already leaning in. They're already asking really good questions. They're already the nurse that when they open up the custom pack and they know they always throw two or three things off of that custom pack without using it. They're the nurse that's going to the leader that can get those things taken off the custom pack so that we're not having waste. When this is also the person that's probably protecting the sterile field, that's doing the right things all the time. So I would say as they move into leadership, continue doing those things, but be a champion in your department for that practice. Be that preceptor. Help others that are not performing up to standard. Make sure that you're the one that is speaking up, even on unpopular topics. That's really hard. Let's just be really
bold and courageous.
Honest with one another. When you are working side by side with a colleague and you see something that is incorrectly done, and you are going to help correct that, that's a difficult discussion. So one of the things, you've heard me talk about this a couple of times, communication. I think I would advise that leader to continue to lean in, continue to, hold the standard, not conform, right? To be courageous and not conform, but also to educate themselves on how to make those communications effective, not abrasive, certainly not abusive, but how to communicate in a way that is really about positive intent. That's what we're about here. We're about positive intent. So communication skills, and then, seeking outside, internal resources to get to know more about the finance workings of the organization and how we can partner that and make our business case for patient safety. And then external. There's a lot of external. There's more and more. There used to not be very many, but there are more and more external ways to get financial acumen, education that is specific to healthcare. That is what's so important, is that it's specific to healthcare. Because whether everybody thinks this or not, we're different in healthcare.
We are different, which would explain, Pam, why in the Center for Perioperative Leadership at AORN, my most frequently asked question or frequently requested resource is help with business and finance in our perioperative environment. And we partner together and put on a business finance series for perioperative leaders. You have a specific module within that, making the business case for safety. Is there anything more that you would add in terms of context that we have developed with that program that you would want to add in closing, Pam?
Yeah, I think about this, Jake. I always say that finance is not my passion, but having the appropriate number of nurses at the bedside or at the OR table, having the right supplies and those supplies available, and having the latest technology is. So we need to learn how to speak the foreign language of business and the foreign language of finance. In that last class that we do together, it's the business case for patient and workforce safety. We talk about fixed and variable cost, but most importantly, we talk about how to take those costs and look at what it costs, what the quality outcome is. So what's the problem I'm trying to solve? What quality am I trying to improve? What measurements am I going to track so that I can demonstrate that, yes, when we implemented this process change, more staffing, a different piece of equipment, we not only, we did what we said we were going to do, and we accomplished the quality outcome, and we accomplished the cost savings as well. So that's kind of a really brief summary of that whole 2-hour class, but it really pulls everything together and helps us understand how we make that business case for patient and workforce safety.
Pam, you and I have worked together in various ways, and I always learn something new from you, even in how you put that, right? We're always nurses first, is what I heard you say.
Yep.
I'm about the patient. When I'm in a leadership role, I'm about my team for the patient. And through that takes the ability to learn some financial and business acumen. So well put, Pam. I love that. Pam, one last question before I let you go. Can you help make the business case for why nurses are essential and make for great leaders of a perioperative setting?
Oh, Jake, I love that question. I didn't set you up to ask that, but it's perfect. Sometimes I have leaders that say, I don't know why they asked me to do the budget. Why doesn't somebody in finance just do this? It's because we know the patient. We know the patient. We know the processes. We know the team. We know the surgeons. We know the anesthesiologist. And we know what it takes to take care of that patient. So if we look at what's most complicated is not the business. What's most complicated is the care of the patient. So with the care of the patient knowledge that the OR nurse has, the OR nursing leader has, we can reach out to resources to help us with the business acumen. And I always tell everybody, all the nurse leaders that I work with, that by finding that finance partner, it brings joy to your work because your work will be easier and you'll get answers. And it brings joy to the finance team's work because they can understand how those business decisions are connecting to the clinical care and the outcomes of the patients. So please, please, please don't give that away. As nursing leaders, as perioperative nurses, we are the best people to know what those patients need and what our workforce needs in order to provide exceptional patient care in the safest manner possible.
Pam, It has been so great having you. Thank you for sharing your wisdom. We'll let you go on that.
Thanks, Jake, and thanks to AORN for giving us the platform to talk about such important issues. And I hope as a result of listening to this, everybody leans in and doesn't conform, but has the courage to protect patient and workforce safety. Thank you.
Thank you, everyone, for tuning in. I'm curious, how do you cultivate a culture of safety in your operating room? Or what might be holding you back? Let us know in the comments below. We'd love hearing from you. Until next time, we'll see you on Periop Talk.
Enjoyed the episode? Please like, comment, and subscribe. For additional Periop content, look for us on Instagram at AORNPics and on Facebook and LinkedIn at AORN. You can also find us at aorn.org. Thanks for listening.